As you've rightly established, I'm Valerie Watts. I'm Chief Executive of the Health and Social Care Board, but I hasten to add I've only been in post since the 1st of July this year, coming hot from local government in Scotland. Pat Cullen, who we have, Pat here, is a Director of Nursing and Allied Health Professionals in the Public Health Agency, and Pat provides nursing advice to me and also to the whole of the Health and Social Care Board. Dean, immediately on my left, is the Director of Commissioning at the Health and Social Care Board. Fionnuala, down at the end of the table, Fionnuala McAndrew, is our Director of Social Care and Children's Services, again at the board. And Michael Bloomfield is our Director of Performance and Corporate Services, also at the Health and Social Care Board. Just at the outset, I would like to add, and as I've already stated, I've only been in post 8 weeks, but I have very quickly come to realise how closely we work in the board along with our colleagues in the Public Health Agency in all matters related to health and social care. But particularly and specifically in relation to matters concerning both the safety and quality of services that are provided. This afternoon, obviously, we will seek to respond to your questions or any points that require clarification during the proceedings this afternoon. But before we attempt to do that, I thought it may be helpful to you for me to briefly provide a little bit of context to the inquiry panel in relation to the roles and responsibilities of the Health and Social Care Board and how it works collaboratively, not just with the Public Health Agency, but also with all of the health and social care trusts across Northern Ireland to ensure the delivery of safe, quality health and quality health and social care services right across the piece. As you may know, the Health and Social Care Board is a relatively young organisation, only having been established in April 2009. It replaced the 4 previous local area health and social services boards, and the Public Health Agency was also established in April 2009. At that time, the responsibilities of the previous 4 local area health and social services board were at that time transferred to the Regional Health and Social Care Board and indeed the Public Health Agency. So the Health and Social Care Board has a range of functions that can be summarised under what I would probably best describe as 3 broad headings. The first of those functions is that of the commissioning role. And primarily this is carried out through 5 local commissioning groups of health and social care services for the needs of the local population across Northern Ireland, and that includes the monitoring the delivery of these services to ensure that health and social care meets established safety and quality standards. The second of those responsibilities is what I would refer to as performance management, and in that, by that I mean ensuring that provider organisations meet the relevant health and social care objectives, targets and standards, including those, of course, set by the Health Minister. And thirdly, last but certainly not least, is what I would best describe as resources management, and by that I mean ensuring the best possible use of the resources, the whole of the resources of the health and social care system, both in terms of quality, accessible services for users, and indeed value for money for the taxpayer. But underpinning all of these functions is our statutory duty of quality in respect of all of the services that the board commissions. And we discharge this duty through a range of processes to ensure that the services commissioned and those delivered within the available resources meet what we determine as established safety and quality standards. And our colleagues in the Public Health Agency work very closely, as I've already said, with the Health and Social Care Board by providing professional input into that commissioning process. Alongside this, we have a Director of Social Care and Children's Services, which is Fionnuala, and she provides the board with expertise and advice on all matters related to social care and children's services, as her title rightly suggests. And we also have a Director of Integrated Care who ensures the delivery of general practice services across the whole of Northern Ireland. But more appropriately, and perhaps more specifically, let me turn to emergency health care. In the board, we all recognise that a key element of the patient experience in an emergency department is the length of time they wait to be seen, the length of time that they wait to be assessed, the length of time that they wait to be treated and admitted or discharged to their home. And the Minister indeed has set targets that 95% of patients attending an emergency department should wait a maximum of 4 hours before admission or discharge, and that absolutely no patient should wait longer than 12 hours. It is regrettable, however, that the Northern Ireland health and social care system has struggled to meet these targets, and as a result, the patient experience has at times been compromised. And I would like to just have it on the record today that the Health and Social Care Board believe that that is totally unacceptable. As I mentioned earlier, the Health and Social Care Board has a statutory role to manage and support improvement in trust performance, including emergency department performance, and we fulfil this role through a range of actions and interventions, including, for example, daily, weekly and monthly monitoring of emergency department activity and performance, also regular performance meetings with the trusts, and also support to trusts to improve emergency department performance, including service audits and providing access to external experts, should we deem that to be appropriate. Also, where appropriate, the board has or provides additional investment to trusts to respond to changes in patterns of demand and support, and also support improvements in performance. But performance difficulties in emergency departments are long-standing, with 12-hour waits unfortunately being a routine feature in Northern Ireland now for many years. However, there are encouraging signs of progress, I also believe, in recent years. And if I can just give you three different sets of figures here. In 2011 and 12, there were 10,200 12-hour breaches. In 2012-13, there were 5,600 12-hour breaches. And in 2014, that was down to just over 3,100 breaches. Again, I don't want to take away from those figures. That is 3,100 breaches too many, but you can see how those figures are absolutely coming down the way in terms of that trend. I think this momentum has been maintained into, in fact, I know that this momentum has been maintained into 14-15, and for the large majority of hospital sites across Northern Ireland, a 12-hour breach is now a wholly exceptional event. I say in most of our hospitals, but indeed not all. But we expect that with the sustained focus and commitment of staff across the whole health and social care system, that further progress can be made. In my early weeks in the job, I have taken the opportunity to visit a number of emergency departments and speak with staff and learn firsthand about some of the difficulties they're facing into. And above all, I have been so impressed by their commitment to service delivery, their dedication, their loyalty, their professionalism, and above all, the pride that they take in the public service that they provide. The increased regional attention and priority being brought to this issue through the establishment of the Unscheduled Care task group established by the Minister, we feel can only further support the delivery of improved performance and indeed patient experience. And I would just like to state that the board is fully involved with the work of this task group.
Thank you. One more minute, and then we'll move into questions, if that's
Okay.
okay.
I'll just finish with this, that, however, I must point out that while resources available to the Northern Ireland health and social care system are unquestionably tight, the board's position is that all trusts have sufficient resources to have no 12-hour breaches, and that they have the capacity to substantially improve 4-hour performance. Maintaining and further improving performance into the coming months will, however, be dependent in part on the ability of the board to fund short-term expansions in capacity to deal with additional service demands over the winter period, as this has been the case in previous years. But fundamentally, this in turn, of course, will be dependent on the outcome of the ongoing budget discussions by the Northern Ireland Executive. And finally, we at the board recognise that when things do go wrong and patients don't receive the care that they should, it's important that lessons are learned and improvements are made as a result of that.
Okay, thank you. I'm going to start with a couple of questions and then pass you to colleagues. In your short statement, you made clear the commitment that the board has to driving forward quality in A&E. I wonder if you could tell us about what you see are the key challenges, both, first of all, resource challenges for that, and the non-resource challenges, management, culture, governance, feedback issues, things that aren't resource intensive. and how you will actually measure whether you are succeeding in driving forward quality beyond the 4-hour and the 12-hour test.
Well, I'd like to bring two colleagues in here. Firstly, I'd like to ask Michael to give you his answer to that question. And also, Dean may want to come in as well from a resourcing issue. One or other may decide, no, the other has said enough, but we'll let colleagues decide on that.
Fine. Thank you, Valerie. Certainly, the issue of resources is a real one, as Valerie mentioned. There are the issues of being able to deal with the increased demand over the winter period, and also to be able to develop services across 7 days. But we do believe, as Valerie has already said, that there's sufficient resources to ensure certainly that no patients wait longer than 12 hours and that the 4-hour performance is substantially improved. Other quality measures and other indicators that the board would routinely assess are around the patient experience. For example, areas such as the number of patients who left an emergency department after registration but before being seen by a decision-making clinician. The time that patients spend from arrival at an A&E department.
Sorry, a bit more directly into the mic. I think we're probably struggling to hear you at the back. Yeah.
Some of the other measures and quality indicators against which we assess and monitor performance and have discussion with trusts in relation to the steps they are taking to address are around issues, in case you missed me, the number of patients who leave an emergency department after they've registered but before they're seen by a clinician, the time taken from arrival to triage, the time taken from triage to initial assessment, and ambulance turnaround times. So there are a range of other indicators as well as the 4-hour and 12-hour, but I would say that the time that patients spend in an emergency department, particularly that 12-hour standard, is a very direct indicator of quality. It is not a good experience for anybody. It's not a dignified experience for anybody to spend 12 hours in an ED department. Those are the areas at which we focus our attention and our efforts with trust to improve, and as Valerie said, there have been and continue to be significant improvements in that regard. Addressing that requires improvements right across the hospital system and beyond into the community services to have the flow of patients. It's very often measured, and the indicator and the experience of patients very often is in the emergency department, but tackling that and addressing that requires action right across the hospital service and beyond discharge into community services.
Can I ask you, before we get to the non-resource questions, just a quick follow-up, which is, we heard this afternoon about, if you like, workforce planning and the importance of workforce planning, and we heard as well that extra resources have gone into A&E, particularly in the Belfast Trust, given what had happened, and I recognise that the Health and Social Care Board is looking beyond Belfast and across Northern Ireland. But in terms of those extra resources and the needs of workforce planning, are we caught up in short-termism, or are there assurances that some of the additional resources will remain in the system, bearing in mind the overall environment in which we're currently operating in financially is not great?
I think, as Valerie and Michael have both alluded to, there is no doubt that resources are tight within health and social care. So whilst Valerie made an important statement around the board's position that there are sufficient resources in the system, notwithstanding the winter pressures issue going into 14-15, it is only just sufficient. I wouldn't want the panel to have any idea that we're sitting on a mountain of spare resources, of spare capacity that can absorb all sorts of peaks and activity. It's absolutely not that. So we're working within a system that is just sufficient and no more. That's the sort of system we have to work in by necessity, given the wider resource picture. In that context, I would see no prospect of us, with the demographic growth within the system, materially changing or reducing that resource. Having said that, there will always be opportunities at some sites to reduce length of stay and potentially to reduce beds, as long as future predictions of demand might allow that. So things are very, very tight in relation to resources, and will continue to be so. I think if I may, to move on to the non-resource issues, you've alluded to one of them already, which is the difficulties, particularly at a number of the smaller sites, in straightforwardly securing additional permanent staff to work within those sites, particularly down the middle and junior medical lines, and we're very, very heavily reliant on locum staff at significant cost in those sites, and there can be difficulties in terms of the ongoing sustainability of services when we are reliant on locum staff in that way. I think some of the other non-resource issues that would be around, notwithstanding some of the heavy investments that have been made in new infrastructure, most recently the new Antrim A&E department, there are pressures elsewhere in terms of staff working in departments that were designed for a different point in time and that don't really reflect the needs of a 21st century healthcare system, or cramped for space, don't allow the space for observation that the clinical staff might wish and that patients might wish, and inevitably, therefore, would provide lower levels of privacy and dignity and so on for the patients using those services. Just a couple of other thoughts in terms of the non-resource challenges. It is a fact for staff working in the health and social care system, particularly staff working in provider organisations at a senior level, and both clinicians and managers, that it is a very complex agenda. The emergency department agenda in itself is a very complex one. As Valerie has alluded to, we see the issue of 4-hour waits and 12-hour waits, and the concerns that remain in a very small number of sites in relation to the latter. But that is only a symptom of wider difficulties within the system in terms of the ability of trust to flow patients through the system, through receiving the care they need and then to be discharged. That's a very easy sentence for me to say, but a very complex process for individual patients to go through. So undoubtedly that is a complex agenda. I think linked to that then as well, the complexity of the agenda more generally faced within health and social care, where we're trying to live within a very tight envelope of resources. We're trying to reform services consistent with the vision set out in transforming your care, and the need to do that with demography coming over the hill. We're trying to make very significant savings targets each year, and the day job as well in terms of just every day in relation to ED, seeing the thousands of patients that are seen across Northern Ireland every day, most of whom have a good experience, but not all, as we've said.
Okay. One final question for me, then I'll pass on to colleagues. I want to also just look at the issue of serious adverse incidents. And I'd like just to give a sense of the role of the board plays in this, and whether you could give us an example of where you think it has worked well, where you have the learning has clearly been drawn from it, and you can see the difference it's made. And I wonder if you have any examples, and this is maybe a slightly less easy one to answer, but where you have seen issues recurring again in serious adverse incidents where it appears that the learning hasn't worked, and what you think what's the cause of that? So where it's worked well, where it hasn't, but just also perhaps preface it with the board's role in how serious adverse incidents work.
Okay, I'll try to very briefly outline the role of the board. The board has been responsible for the management of the serious adverse incident procedure since May 2010, when it was delegated that responsibility from the department. Every serious adverse incident that is reported across health and social care, both from trusts but also from primary care, are reported to the board. Every one of those is appointed a designated review officer, who is either a board or a public health agency officer, in the vast majority of cases a professional officer from the background that the incident relates to. That designated review officer liaises closely with the organisation that submitted the incident, who is ultimately responsible for carrying out the investigation, and they do that to satisfy themselves and therefore satisfy the board on the robustness of the investigation. And it is only when the designated review officer is satisfied that the investigation has been robustly concluded, that the membership of the investigation team is thorough, that the designated review officer signs off, which effectively closes the serious adverse incident. Their role at that stage, and the primary role and indeed the primary interest of the board in serious adverse incidents, is at that stage to identify learning, both local and in particular regional learning. and we have structures in place with multidisciplinary groups who review all of those closed cases, identify and discuss possible learning, and we agree what steps need to be taken in those, and there's a range of measures that are taken. For example, a learning letter would be issued to the service by the relevant professional, and I'll maybe ask one of my colleagues, Pat or Fionnuala, to highlight an example of one of those. We have mechanisms in place then within the Board and Public Health Agency to monitor the implementation of those learning letters. They'll specify the actions that are required, and we follow that up and seek assurances from the provider organisations that they have done that. We've also recently strengthened the arrangements in relation to serious adverse incidents to ensure appropriate involvement with families and patients and service users in the serious adverse incident process. That is very clear in the revised procedure that was issued last October. But also as part of that, we have issued a checklist that has to accompany every investigation to specify exactly the extent of family involvement, to ensure families are fully aware and have the opportunity to participate as they wish. And we've recently, at the department's request, developed guidance on what effective family involvement is. You raised the issue of having identified an issue from a serious adverse incident. Does that ever recur? Certainly the aim of the SAI procedure is to minimise the likelihood of events recurring and to ensure that learning from what happens in one place is quickly shared across the region. But of course the very nature of it means that yes, from time to time a similar issue would occur. It is not a guarantee that a similar issue would not reoccur, but the aim and the expectation of the SAI procedure is the likelihood of that is seriously reduced, particularly where learning has been identified and a learning letter has been issued. But perhaps one of my colleagues might want to highlight a particular example of where we have taken that approach and believe that it has been effective.
Thanks, Michael. And just to say, as Michael has said, we have very comprehensive processes in place for the review of all SAIs. So, as Michael has already stated, the Trust will carry out a comprehensive root cause analysis of an incident. That report is submitted to the Health and Social Care Board, and a designated review officer is allocated to work through the content of the report, including the recommendations. And the principal reason why the professional allocated will work through the report is to highlight, well, first of all, that those recommendations are appropriate and applicable and that they are applied in a rigorous manner. And secondly then, to determine the regional learning that may arise from the review of that serious adverse incident. And once we determine that regional learning is required, we work with the Trust lead professionals and other professional staff in the department and right across the service to complete a learning letter, what we determine as a learning letter. There's a rigorous process for going through that because we obviously have to apply the best evidence base, and we look across to NICE guidance and other guidance, that's College of Emergency Medicine, for example, guidance, and we take account of the best evidence and then we complete the learning letter. So the one that was issued in relation to emergency departments more recently was on the as a result of individual patients who presented with head injuries, and those patients at the time of presentation at the emergency department were currently taking warfarin, and they should have been triaged at a Category 4 category. Unfortunately, on those occasions, those patients were not categorised within that category, and the professionals failed to pick up that those patients were indeed in receipt of warfarin therapy, and consequently there was a delay in their treatment. So those issues were comprehensively considered by ourselves within the SAI report, and a learning letter has been issued to the service, that indicates the appropriate treatment and care that we expect patients who are receiving or on warfarin therapy to receive when they arrive at an emergency department. We also then have monitoring arrangements in place within the two organisations to ensure that the learning letter is applied. It's not just issued to the service, but indeed it is appropriately applied and patients are in receipt of the appropriate treatment following the learning letter being implemented.
Okay, thank you. Any examples where you've seen something recur, where you thought the learning letter, when I understand the process, where you think, have ever seen something has happened again and thought, this process doesn't seem to have worked? Might have happened in a different trust, even though it might be. Are there any examples of that, or to date in the 4 years of this, are you confident that the learning of the SAIs is always applied in practice?
Not so much an example, but certainly wouldn't want to give the impression that having identified an issue from an SAI and issued a learning letter, that there are no further instances of that. There will be times, there have been times when that has happened. What then happens is those specific cases are followed up with the professional officers from the board or public health agency with the trust concerned, given it is being the subject of a learning letter. But the very nature of healthcare will mean there will be times when something happens and a similar event occurs. As I say, the aim, the objective of it is to reduce the likelihood. It is impossible to totally eliminate that.
Okay, I'll pass you on to Marion.
I have only one question. The board's role is to commission, to assess the health needs of the people of Northern Ireland and to provide services to meet that needs. And my question has two parts to it, really. Could you discuss how you carry out that role in relation to the provision of emergency care services, and also more specifically look at the example of patients with a mental health need and the advice to create places of safety for them in each emergency department. And I'm wondering, in your reply, could you give some regard to using service users' participation in planning for the services?
So Dean's going to answer the first question, part of your question, and Fionnuala will come in relation to mental health need.
Okay. Thanks. It's certainly a very important issue, and we can never do too much of it. You'll have heard today already, I'm sure, and Valerie's alluded to it in her introductory remarks as to, in broad terms, what commissioning is, but I think it's useful to just rehearse it again. So at its simplest level, it is about understanding the needs of the population, the needs of patients and carers. It is about us as a commissioning board, primarily through the 5 local commissioning groups, developing a service model and commissioning services in response to those needs. And it's about then ensuring that that service model is consistently delivered by the provider organisations. In most or all of those stages, there's opportunities to involve both the staff within provider organisations and, crucially, to involve patients and carers. And we've made huge strides since the board was established to progress that agenda. I think we still have further to go, but I could spend the next hour explaining or giving examples of how and where we have done that. Perhaps specifically, though, in relation to whether that's me or the microphone, specifically in relation to emergency department services, to give an example very close to home in terms of Belfast. There was an initiative involving colleagues from the Public Health Agency, the Belfast Local Commissioning Group, and the West Belfast Partnership, where the views of over 200 people who had used emergency departments were surveyed with a view to informing how services might evolve in future. More generally, Pat may wish to expand on this, and indeed Charlotte McCardle from the department may have alluded to this earlier on today, in terms of the initiative being led by the PHA in partnership with the board around the 10,000 Voices initiative. One of the key foci of that at the start was around securing input from people using ED departments. So in that regard, nearly 5,000 completed questionnaires were returned by patients who'd used ED departments across Northern Ireland. Some 3,000 patient stories were obtained from patients who had used ED services across Northern Ireland. And in addition to that, over a 7-day period in each of the ED departments within Northern Ireland, the practice of clinicians was observed with a view to identifying lessons going forward. There's a comprehensive action plan that has come out of that and been fed into the commissioning process, as well, with appropriate follow-up around it. Much of that action plan, many of the issues that were identified, are very much in the space of respecting patients' rights, privacy, dignity, and so on. I don't know whether you would wish to add to that.
No, except that this is an initiative that we're very proud of. We have full engagement right across the region in relation to 10,000 voices. It was our ambition to, for this initiative, that it would, the key objective was to have experience-led commissioning, where we believe that our commissioning processes will be strengthened by listening to the voice of the patient. And we set ourselves an ambitious aim to gather 10,000 stories from patients and clients. And as Dean has said, we have actually been delighted with the response from patients and clients in terms of telling their story. And that's right across a range from young people right through to our very old population. And we did commence the work within our emergency departments because we realised that that's where we needed to start. And we honestly realised that there were issues that we needed to address within our emergency departments, and we worked with the trust to engage with our patients going through that service from the outset.
I could make a response then to the mental health issues. If I could start by just saying between July 13 and June 14, there were about 12,000 people who attended our ED departments, either with mental health issues or self-harm issues. So I think when you look at the scale of attendance, it is a key issue that we pay due regard to the experience of mental health patients along a whole pathway. And that's been the work of the self-harm group, which has been set up by the Health and Social Care Board and the Public Health Agency. A number of measures have been brought forward. Our ambition is that people with mental health issues are seen within a target of no more than 2 hours. At the moment, we appear, although I will admit that we haven't got robust data around the waiting time, but anecdotally we are being told that by and large that is being met. The important issue, I think, is that each Northern Ireland Trust has declared their ED department as a place of safety, reflecting the mental health order. We have applied guidelines in relation to that, and service users have been involved in the development and oversight of the guidelines. But I think it's more than just a place of safety. It's really important that when people are brought to a place of safety, that the transfer, particularly from the police to the healthcare worker, is streamlined and to, I suppose, minimise the vulnerabilities for the mental health patient in ED departments. So we do have a protocol with PSNI in relation to the attendance of mental health patients who are in crisis in the ED department. If I could just briefly say some of the outworkings of the self-harm group relate to the implementation of a European mental health care pathway. And we do have 2 pathways operating in Northern Ireland, one for children and one for adults. It would be remiss of me to say that there isn't more work that needs to be done to make sure that the response is consistent across our EDs, but we're working very closely on that at the moment. The self-harm group has representatives from service users on the group, and we've also established a reference group, a much broader reference group with service user involvement, where all the products from the self-harm group are debated and discussed to give service users the opportunity to provide their views and comments and almost, I suppose, co-produce the materials that come out of the self-harm group. So I hope that answers the question. Fine, thank you very much, Nina. I've only one supplementary really for Dean. In assessing the number and the capacity of emergency departments. I'm wondering in terms of bed capacity and patient flow and the 12-hour waits, how does that fit into the board's assessment of needs in relation to determining?
Well, Marion, that wouldn't fit into the assessment of need per se. That would be up front, and so the capacity is a separate issue. So in broad terms around unscheduled care, we would look at the size of the population, the demographic of the population, any inequalities or other issues that might be relevant in the population, things that might change the nature or volume of unscheduled care services that population might require. We seek then to determine how best to respond to that unscheduled care need, be it a response in terms of supporting people who live independently, be it a response that's needed in primary care in a GP practice or in an out-of-hours service, be it a response in a lower-end minor injuries unit, or it potentially is a response that they need the full services of a 24/7 A&E department. And if it's that bit of need that we're responding to and potentially then needing to be admitted to a major hospital, then we would have a process to working with provider organisations to look at volumes of activity that have in the past gone through the bed stock of that hospital, to look at the length of stay associated with that, look at the complexity of that activity, and reach a view as to whether the level of capacity that exists within the organisation can reasonably respond to the demand that we would expect to see in the subsequent year, and that being benchmarked against both peer organisations within Northern Ireland and against relevant organisations across the water as well. So quite a complex series of things to allow us to reach the conclusion that we referred to earlier on today.
Thanks very much. Regrettably, I've got quite a few questions. Can I ask them and then maybe some are answered in an informal written note later, but we're out of time now. But I'll ask the questions and then perhaps Les will be guided by you how to proceed. So first of all, the Compton report. I'm very impressed by the Compton report. But I am conscious that it's very light on governance issues, which I find a bit curious. I don't know why it's so light on governance issues, because we all know governance is extremely important, but there we are. As we all know, the Minister has recently announced that Cillian Donaldson is going to report on governance, and I think that's most welcome. That's really good news. So my question is, in your view, from where you sit, how could health governance be enhanced? How could health governance be enhanced? Second question related to that, it's really rather a sort of fundamental question, but what do you understand by governance, by health governance? And in order, just if I can stick my neck out, adopting a sort of human rights perspective, I think that health governance has the following elements, but I might be wrong, and I'd be interested to know your view. But it seems to me that health governance includes a requirement of transparency. It requires as much participation as possible. Of course, there are limits to that. Participation is a really tricky concept. But as much participation as possible, whether it's public participation, patient participation, or staff or health professional participation. It seems to me that health governance would include monitoring, and we've heard a lot about monitoring, very appropriately, so the monitoring of appropriate indicators and so forth. But I think it's much more than monitoring. It's also, governance is some capacity to take stock and evaluate what has been displayed by the data. So in other words, a sort of a review component to check that promises are being kept, contracts are And then I think in governance there's also some sort of remedial action that might be required in some cases. It might be cancellation of a contract, or it might be whatever. So I'm sure that's not exhaustive, and I'm sure it's contested, but the governance is so really important to what we're talking about that I just wanted to throw out those possible components of governance. And if you disagree, I'm really, genuinely, really interested. Third, and it might be that this is taking Marion's discussion with Dean in particular a bit further. If I'm repeating, I'm sorry. But it's about special groups. And Marion, you focus quite appropriately on special groups with individuals with mental health problems. But of course, there are lots of other special groups too. There's children, there are elderly, there are intravenous drug users, there are asylum seekers, there are people with brain damage. I don't mean that's why they're in. I don't mean that because of some incident they're in accident and emergency. I mean they've got an earlier condition of brain damage, and then they have to go back to accident and emergency, and I would imagine they require some sort of special treatment when they arrive, and the list could go on. So I'm just trying to get a sense of whether or not in your commissioning you require trusts to give special attention to those groups when, regrettably, sometimes they turn up at ED. And I'm not so interested in how many should they expect, but that I think Dean has touched on. It's not so much the sort of demographic issue, how many might be expected. It's having got there, do you require in your commissioning that the emergency departments give special attention to the special needs of these special groups? I'm a lawyer, right? So excuse one lawyer question. It's about international human rights law. Okay, so the United Kingdom, to its great credit, has signed up to a number of really important international human rights treaties. And these are legally binding obligations, legally binding at least at the international level. And they include, for instance, ratification of the International Covenant on Economic, Social, Cultural Rights. That includes an important provision on the right to health. And it includes the Convention on the Rights of the Child, which that convention has a really important provision on children's health rights. So, I could go on, but I won't. My point is, frankly speaking, and it's not a reproachful question, I just need to know, to what degree do people, officials, whoever, remind you of these binding international human rights obligations that pertain to health? And I think my last question is probably the easiest of the lot, and it comes from Les's question, one of Les's questions. It's about his question about non-resource issues, and the problem, as I understand it, you'll correct me please if I'm wrong, but the problem of, in some places, an over-reliance on locums, if that's the right word, loci, locums, whatever. And my question is, well, I suppose my observation first is that this is a problem that, in my experience, all health systems I've looked at, they encounter this problem of getting certain health professionals to certain places, and there are lots of sort of incentives can be added to try and address this real problem. I'm not diminishing the problem, it's a real problem. So is it possible to, or rather in your commissioning, do you encourage, permit, whatever, could make contractually required incentives, maybe financial incentives, they could be non-financial incentives, like more holidays or whatever, to try and get the people, get the right health professionals in at the right place? I haven't been terribly lucid on that last point, but have you got it?
Yes.
Okay.
Well, firstly, Mr. Hunt, can I just say that I welcome your comments in relation to the, as you referred, the John Compton report, the Transforming Your Care report. because in relation to where we're sitting at the board at the minute, and maybe I can say this coming into the system with a fresh pair of eyes, we don't have any other option than to look at how we transform your care, because unfortunately we are living in a world at the moment it's the public sector mantra at the minute, where we're being expected to do an awful lot more with less, or with the same, or with a set of diminishing resources. And obviously more learned colleagues and I today have discussed the pressure in relation to demographics and everything that goes with that. So simply to sit back and not look at how we do things differently is not an option for anyone I know working across the whole of the health and social care system, and the information that I have picked up to date. Whether you call it transforming your care, or whether you call it continuous improvement, or looking at how we do things more innovatively or more creatively, that has got to be the name of the health and social care game at the moment. Do I agree with your the various components there that you've outlined in relation to what you consider a health governance system to include? You talk about things like transparency and participation, monitoring, performance management, taking stock and evaluation, the monitoring component, and then learning from that and taking any remedial action. I think that's the land we all live in at the minute. It goes without saying that those are the elements of a health governance system that we would all agree with, and perhaps if we write to you then in relation to that, there would be other elements that we would see being built into that. I'm not too sure why Mr. Compton's review did not look at governance arrangements per se, but we absolutely welcome the Surley and Donaldson report, and maybe that's the bit that needs to underpin the Transforming Your Care report.
Okay, I think the second question was about special groups in terms of specific attention you pay as to how they are treated.
Okay. There are, I forget, you use a form of words that I'm not sure I would agree with in terms of, but are there particular groups of patients with particular sets of needs that require a different approach within an ED department, might be the way I would phrase it. And yes, there are. Fionnuala's alluded to the approach that we take within the mental health arena. Maybe just to give a couple more examples as well. One would be in relation to, and again, as with many things, works in progress, but an awareness of the issue and further progress to be made. Ladies and gentlemen undergoing oncology treatment, and sometimes difficulties with that treatment, and sometimes those difficulties being of such significance that it necessitates a trip to an emergency department. What has happened, what can happen is if those patients haven't been able to be identified, they go through all of the traditional ED department processes, when actually that's entirely inappropriate for their needs. They need to bypass that, and that's an active issue that we're pursuing with provider organisations, working with them to make sure there's a very clear pathway for those patients that isn't the traditional one. And another group of patients, a much larger group of patients that would be also worthy of a particular approach would obviously be our elderly population. And again, working with provider organisations, we're already admitting a material proportion of the elderly population, other than through the traditional emergency department route. More than 10% of patients last year of elderly, patients in total, were direct admissions, either into a ward directly or into an acute medical assessment unit, bypassing entirely the emergency department. Again, we believe there's scope to substantially increase that number, perhaps potentially double or treble the percentage of patients who can be admitted without going through the emergency department process in the first place. And clearly, if you're a frail elderly person with a particular set of needs that aren't consistent with that, that would be a potential opportunity to compromise, again, privacy, dignity, patient experience, and so on. So again, a very live issue for us. Very substantial progress has been made on that issue already, and very ambitious targets going forward, not unconnected to transforming your care. Yes, it does. Yes, it does.
Very quickly, the two final questions. I'll ask you very brief, but how do you utilise international human rights obligations around right to health? Do do you, first of all, and if so, how? And then the second one was just the question of locums, and are there incentives and other ways in which you've tried to deal with recruitment issues?
Sorry, we can deal with the locums answer first?
Yeah, sure.
The locums one is, again, as many of these issues are, they're multifaceted. I think you said in your question, or the implication was that the doctors and other staff are there if only the incentives were juicy enough to attract them. Actually, the difficulty can be more often than not it is simply a capacity issue. There aren't enough doctors there, full stop. And one of the issues we have had as a commissioning organisation in some specialty areas is not per se filling individual posts, but securing net additionality to the system in Northern Ireland. A lot of the recruitment tends to be just moving the staff around within the system, rather than actually adding to the quantum of staff that is there. So we face issues in some specialty areas of the number of doctors, full stop. And then to compound that in some areas as well, which you're also alluding to, there are site-specific issues which may make those sites less attractive to work on. There are things that can be done. We wouldn't explicitly, other than by exception, commission to respond to those things. But where, and there's a particular example that because of the fact that you could name the post, with some very, very problematic to recruit posts, and often these are problematic to recruit at a UK level, where the post is very, very problematic to recruit to in conjunction with the provider organisation, and often with the department, given the risk of a precedent being set, a particular set of measures will be put in place to allow a post to be filled that could otherwise not be filled, where failing to do so would have a material impact on some service development. But they would be by exception rather than a routine arrangement we would have in place. So we wouldn't routinely commission. It would be unhelpful to routinely commission, because that you'd effectively just raise the bar, and that would become the new norm. But undoubtedly at the margins, trust as provider organisations have to take steps to ensure hard to fill posts are filled either permanently or temporarily.
Okay, finally, the utilisation of human rights frameworks in the work that you do, does that have any resonance currently or not?
I'm not too sure if I'm interpreting your question correctly, but what I would say is that again, coming in with a fairly fresh pair of eyes, again from a local government setting, I hasten to add, in Scotland, I actually think that an awful lot of what is in that international legislation is implicit in a lot of what we do in terms of how we deliver healthcare across the piece here in Northern Ireland. And but I'm vaguely aware that I think in Scotland they have legislated around this, but I'm not aware of the detail. Maybe other colleagues have more of the detail than I have. But I think in principle we would be happy, to explore if a similar arrangement to Scotland might be implemented locally, but we would really need to dig down into that and explore that. And ultimately that wouldn't be a decision for the board, but that would be a decision for the department. Looking at it from an organisational perspective, whilst we want to do everything, absolutely everything right in relation to affording people their human rights in terms of accessing health care and everything that goes with that, I having lived in a legislative world for the last 32 years, I believe it is much better for the culture of the organisation if we can naturally introduce these things where staff automatically take on ownership and an interest and an acceptance around doing the right things rather than have it forced on them. But that is only a personal opinion in terms of organisational management.
Just add to, okay, I'll be brief, just add to Valerie's comments. I think the first thing to say is that we believe that we adopt a rights-based approach to the delivery of services. So my example from that would be that the core values of the human rights legislation can be read across to the patient-client standards, for example, that we use to monitor patient experience and as you've already heard, one of the recent pieces we did was in ED. I think that some of the convention rights are better embedded than others, if I'm really honest. So the UNCRC, for example, we have been working for years. It is a fundamental plank of the strategies that have been developed and the services that we have developed. But more recently, I think I could point to two examples where we're absolutely looking at commissioning decisions based on a rights-based evaluation or a rights-based framework. And I would refer to our recent work on our review of statutory residential homes, for example, where we absolutely took convention rights and looked at how they would impact on our processes for considering the future of that area of service provision. We've also embarked on a piece of work, and it's not directly related to ED, but it's just an example of where convention rights are affecting our commissioning frameworks, is in the area of sensory disability, where we are developing a rights-based commissioning framework for people with sensory disability based on the Disability Convention rights. So in answer to your question, are we mindful of them? Are they something that we consider? Yes, they are, and I think we can point to examples where we are beginning to embrace those rights in our